Hello everyone, welcome back again. This is PT Forensics, episode number 6. We're just rolling along here. Just as a quick little shout out, I hope everyone enjoyed the dry needling debate we had last week. It was a good time for all to have. I think we both learned some good things there. So overall, good debate, good discussion. We are moving on to this next week here. We have another interesting kind of format coming for you guys. We're going to do a anterior cruciate ligament injury series, or obviously in short, an ACL series, where we will be discussing all things ACL. It is one of my favorite patient populations to treat. I believe, Corey, it is also yours.
Absolutely.
It's a fun one. Not so much for the patient, but for us, it could be pretty fun. So just to give you a little breakdown, this week we're going to start in the beginning. So we're going to do more of a epidemiology. Going to give you some numbers. Going to give you some risk factors. Going to talk some variables for you about ACL injury itself. The following week, we're going to be talking about different surgeries, graft choices. What's the literature say between early rehab versus late rehab versus getting surgery versus not getting surgery? So we'll jump into all of those good things. And then the final ACL series will be all about progression of the rehab process and then that eventual return to sport type phase. So we got a lot of information coming at you in these next couple weeks. We hope you all enjoy it as we have enjoyed it as well, putting it all together. So jumping right into it, Corey's gonna take it away.
Thanks, Dave. Yeah, we were kind of talking before that this is really a fun patient population to treat because if you're seeing them from their initial injury, you're seeing them through a whole spectrum of different presentations. They might become acutely really swollen, really painful, and then if they do decide to have surgery, you're following them through that whole process. And when you get someone back to full sport potential, it is really kind of a rewarding population. With that said, though, I delved into the knee sprain guidelines put up with the JOSPT, the Journal of Orthopedic and Sports Physical Therapy. They periodically do these clinical practice guidelines for different patient populations. And they did one on knee sprain. So they kind of talked about all different ligaments. And they spent a lot of time on the rehab phase after surgery, but I did want to pull out some important information, background information, more epidemiological type numbers. The first thing I pulled out is that the rate of secondary ACL tear is about 15%. 7% on the ipsilateral side. So if you tore your right ACL, got it repaired or reconstructed, 7% tore that same one again, and 8% retore the other side. Another thing we talked about briefly before is that these patients, these are low-hanging fruit for PTs. These are patients that we ought to be doing a little bit better with, I think, because that re-tear rate is pretty high. And a lot of times when we get into the biomechanical analysis here, these are all things that we are good at doing and that we should be able to control when you talk at knee, hip, and ankle mechanics. Some other numbers I have coming at you. Patients younger than 25 had a re-tear rate of 21%. Again, we're finding these patients are typically pretty young because they're mostly athletic. When you go into the different sports what we most commonly see ACL tears, in girls, the highest per season injury risk levels were in soccer, basketball, and lacrosse. And in boys was American football, lacrosse, and soccer. All sports that involve a heavy level of cutting, rapid acceleration, deceleration, jumping, landing, which is, as we all know, is the more common ways that people tear their ACL. So some incidence numbers, ACL reconstruction went from 86,000-ish in 1994 to 130,000-ish in 2006. Lots of reported reasons why that stuff happens. And, one of the bigger reasons is with Title IX, a lot more female athletes. So, percentage-wise, a lot more females are getting involved in sports, and that tends to be the population where they're tearing their ACLs most often. So some risk factors along those same lines, female sex being one of them. Dry weather was actually found to be a little bit higher risk, as well as turf surface. So they found that people were tearing their ACL more on a turf surface versus a natural grass.
And Corey, not to cut you off there, but I've read that before, and I find that a really interesting risk factor for
Certainly.
ACL injuries, especially the turf surface.
Yeah.
I think I don't know what the research says about this in particular, but I can only imagine that part of the reason why we've seen an increase in ACL injuries, really, part of the reasons, there's a ton, obviously, but part of it is that I think kids are playing full year sports on these turf surfaces, especially where you and I live up in the Northeast. If these kids want to be playing these outdoor sports all year long, then they're going to be playing on turf. And I think it has I think it has an underlying factor that a lot of people don't think about as far as these ACL injuries. So I didn't mean to cut you off, but I just found this to be just a really interesting point, something to sort of maybe shed some light on.
Yeah, absolutely. And you bring up a good point as far as, early sports specialization, which, again, if you're, playing the same sport year round, especially, now we're starting to look at different things like what type of surface are you playing on? Does that matter? That's probably a nice discussion for another day as well. Mm-hmm. So last few couple risk factors, they talked about some different intrinsic factors, female sex being one. They looked at a narrow intercondylar femoral notch size, so potentially a smaller surface where the ACL is originating there. Greater anterior to posterior tibiofemoral joint laxity. So we've had those patients that if you test an anterior posterior drawer, they're already super lax and maybe on both sides. Another risk factor was prior ACL reconstruction, right? So if you have your ACL torn and you get it reconstructed, you're more likely to have it done again. And also they found there's a familial predisposition. It seems that folks who tear their ACLs tend to breed folks who tear their ACL. Last couple things from the clinical practice guideline, just touching on diagnosis. They kind of gave a little blurb about what sort of things you should be looking for. Again, this is probably not news to anybody, but they tend to be injured in an acceleration-deceleration injury with a valgus force to the knee, and it tends to be more towards hip extension. So, folks are landing or cutting in a less flexed position of the knee, so they tend to be a little bit more upright, a little more extended at the knee. There tends to be the sound of a pop. So you've always heard the story, somebody tore their ACL, they heard that big pop, and then a hemarthrosis within 12 hours post-injury. They tend to complain of giving way. So now they have some poor stability at the knee. So now if they're just walking or going up and down stairs, their knee might give way on them. Some quick stats on the Lachman's and pivot shift test as a diagnostic test for ACL injury. The Lachman's test was reported to have sensitivity of 85% and specificity of 94%. So that's looking like a pretty good test. And the pivot shift test with a sensitivity of 24, so pretty low rule out value there, and a specificity of 98%. So if you're testing positive in the pivot shift, it's looking like you have an ACL tear. They also just talked quickly about functional tests. And this is probably what you'd be doing with someone who you just suspected a sprain of the ACL, because it has the 6-meter timed hop test, and you would be comparing that to see if it was less than 80% of the contralateral side. Isometric quad strength, same thing, less than 80% of contralateral side. That's going to be significant. And again, these are important ones for documentation as well. And history of giving way in more than 2 activities of daily living. We're going to delve into the clinical practice guidelines a little bit more probably when we get into the second and third episode of this series. So we'll put it on the back burner for now. I just want to touch on a quick article I had called Biomechanics of Patellofemoral Pain and ACL Injury in Sports. So quickly, this is a systematic review. I had 15 studies looking at a whole variety of biomechanical variables. And they had 3 case control, 5 prospective cohort, and 7 case studies. Again, they were looking to find studies that had a mechanism of injury that was related to ACL. So either a landing, change of direction, or rapid deceleration study, where they looked at kinematic and kinetic variables. 2 studies reported on hip mechanics, and they found increased hip flexion to be a risk factor associated with injury. So those folks were landing or cutting with a little more hip flexion. But and that was for ACL tears. For the patellofemoral pain population, they found that an increased adduction angle, increased adduction impulse, increased internal rotation angle, and increased flexion angle were all biomechanical variables. And these studies, these populations are commonly put together because the mechanism of injury is usually pretty similar. It's that classic patient, you have them do a jump down test and their knees go cranking inwards towards valgus. Their hips are internally rotated and adducted. And this is just putting some cold hard facts to some of those observations that we've seen for years. So for the knee biomechanics, the variables that were associated with ACL injury were decreased flexion angle. Again, so that's a patient who's landing in a very extended knee. And when you combine that with some torque to the knee, like maybe you're landing and cutting, that tends to be where folks are tearing their ACL, or at least putting them at risk for a tear of ACL, and is what they were looking at in this study. So decreased flexion angle, increased abduction angle, so they're talking about knee valgus, increased abduction moment, and increased internal rotation angle. They had limited evidence for the ankle biomechanics, but they did find one low-quality study finding decreased plantar flexion as a risk factor for ACL injury. Again, these things all make sense, right? These are observations that we tend to see pretty commonly. And if you don't, routinely do jump down tests on your female athletes, I suggest you do, because it gives you a lot of information. You might be able to pull out some of those patients who are at a high risk of ACL tear. That's all I got from my studies. Dave, what do you got?
Very good stuff. Appreciate it, Corey. So I have a similar study that Corey had discussed as well. So the first study I'm going to be talking about, it's called Mechanism of Injury and Risk Factors for ACL Injury. The article comes from I've never heard of this journal, but sounds interesting. It comes from the Operative Techniques in Sports Medicine Journal, back in 2015 by Wetters et al. So essentially what it said, it actually breaks it up into non-contact and contact ACL injuries. So to start with, non-contact ACL injuries is very much what Corey had discussed. You're looking at a change in velocity, and some sort of multi-directional forces going on at the knee in a weight-bearing position. So what they termed this was multiplanar loading, which I thought was pretty interesting. And then similar to what Corey had mentioned, you have these sagittal plane and these frontal plane loads. So, the knee and hip flexion and extension, and then you have, the hip abduction, adduction with the knee valgus varus movement. So very similar to what we had discussed before. And then as well, there's a piece to discuss about imbalanced muscle contraction forces of the quads and hamstrings. So something to go into it a little bit later. So breaking it down a little bit more biomechanically, so the ACL is considered the primary restraint of the knee with anterior loading of the tibia. So when you get this tibia moving anteriorly underneath the femur, so the ACL, that's the prime preventer from that translation, from that movement, especially when the knee is in more of an extension range, which is why, as Corey had mentioned before, you usually see people with injuries of the ACL when they're in more of extension, because the ACL has to compete with all the loads that are occurring. So they talk about, so that's what the ACL does really. So there's three other muscle groups that sort of come into play here. So one is the quadriceps on the front. You got the gastroc that comes right up behind the knee, and then you have the hamstring, which attaches right below the knee. And all these different muscle groups are thought to resist or increase some of that tibial translation. So the quadriceps and the gastroc are thought to increase the anterior translation, and the hamstrings are thought to resist it, so give a little support. But studies have found that the gastrocnemius, we're still not really sure what it does. It's inconclusive on that anterior tibial load or anterior tibial translation. And that even though the hamstrings are there to help protect the ACL a little bit, it gives a posterior translation to the knee. This protective aspect of the hamstring is reduced when entering lower degrees of knee flexion. So again, you get into that more extended position, the hamstring doesn't have as much of a pull. It can't really affect as much force as it would if the knee was flexed more. And then finally, the quadriceps was actually found to provide more of a compressive force through the knee joint. But that would also increase the tension of the ACL. So the position of the knee, again, has been found to implicate ACL injury. When you get those sort of low degrees of flexion going into hyperextension, you get these increased injuries. And then moving on to contact mechanisms. So when you're thinking about more of a contact injury to the ACL, it's a high energy knee dislocation, traumatic, just sort of event where, you get, it's essentially the same as the non-contact, but you just get a little bit more intense, right? So that knee dislocates, and then you got a whole bunch of other stuff happening in there, but or any sort of traumatic on-field injuries. You could go on YouTube and spend hours upon hours looking at all the different ACL injuries. So, but they are different. They should be classified as different as well. Because you'll get different injuries associated with them. So yeah, moving on to that. We'll probably actually touch on that a little bit more when we go into the rehab portion. Because I believe there is actually I believe that there's a difference between non-contact ACL and then contact ACL injuries. Because for a lot of these contact ACL injuries, you can't really do much about it, right? So in these non-contact ACL injuries, usually it is some sort of biomechanical issue that you're trying to work on. So different mindsets there. And then Corey did touch on some of the risk factors. I just want to bring up some other ones real quick. One of them is increased joint laxity, so the ability of the knee joint to go into hyperextension. The Q angle, which is, there's actually conflicting reports on the effect of the Q angle on ACL injury. Some show that there is a relationship, others show that there is not. But what they do state in the article is that what would be a better measure would be to check the ratio of the pelvic width to the femoral length. And that is potentially a better measurement than the Q angle for measuring a risk factor for ACL injury. Some other ones are anterior pelvic tilt, femoral anteversion, subtalar pronation, which there's some conflicting studies, and BMI, which again there are also some conflicting studies. So some very similar stuff to what Corey had mentioned before, but also a little different as well. Lastly, I'll talk very briefly about this last study. I was just purely interested in it. I had never thought of this before or really seen much of it. And the study is the effect of foot landing position on biomechanical risk factors associated with ACL injury. Now, to be honest, I usually don't look at the foot as much as I probably should. I'm usually looking more at the knee and the hips when I am looking at some sort of jump landing task or any landing task in general. But this study looked at the foot, whether someone what occurs further up the chain when someone lands from a jump position in the toe in, the toe out, and the neutral position, and these the effects it has on the biomechanical risk factors for ACL injury. So 10 males, 10 females, 20 to 30 years old, no prior injuries or history of ACLs. What these people did was they had 3 trials of they jumped from a 30-centimeter box, again, landing in those 3 different positions. It was all randomized. And essentially what they find is that when you land in the toe-in position, it increases the knee abduction angle and increases hip adduction angle, which means you're going into that valgus movement more with a toe-in position, which is associated with increased ACL risk of ACL injury. And then landing with a toe in was also found to increase tibial internal rotation. Therefore, looking at this foot position, you can alter some other lower extremity biomechanics further up the chain, especially when you're looking at some of these sports, like Corey had mentioned, like a basketball or a soccer, volleyball. So all these different sports that really have a lot of jumping and cutting and deceleration, turning, twisting, all this kind of stuff. So that is it for the 2 of my studies. Pretty quick, short, to the point. I thought that they were both somewhat of eye-openers to me in some aspects of ACL injuries that I had not previously thought of. For example, again, what I had just mentioned was the foot landing position, whether they're landing toe in, toe out, or neutral. And really that study only talked about how toe in was bad. It didn't really talk about the other effects of the toe out or the neutral. It just essentially said toe in was bad, change that up. And then from the earlier study, differentiating that contact versus non-contact ACL injuries. And then the other big takeaway I got from that was the whole Q angle. So Q angle actually, there's some conflicting evidence out there about whether it is a risk factor, but what you should look for, more importantly, is, again, that pelvic width to the femoral length, because that will really give you a better sense of, some of these torques and forces that are occurring at the knee. So that's what I got. Corey, any tips or any other?
Yeah, I have a few important takeaways, I think, from all these things. The first is that you can hear from what both Dave and I had said regarding our articles is that there's a lot of information that you can get away from the knee. The knee generally is going to move in flexion and extension. Yeah, you're going to get some valgus force and you're going to get some internal rotation force, but generally that's kind of what it's meant to do, is flexion and extension, and most importantly a shock absorber. But we can, we're doing a disservice if we're only focused on the knee and the ACL patients, if we're just hammering quads and hammies all day long, and we're missing the hip external rotators. And, Dave mentioned he, rarely looks at the foot. I would say I agree. I probably don't look at the foot enough. A lot of times I'm looking at ankle flexibility, certainly, but how good is their foot at absorbing forces, especially in a high impact or high speed activity such as soccer or basketball? If that person can't load up through their foot initially, where's the breakdown going to happen? I would say most commonly it happens at the knee. But again, the hips going above the chain, looking at the hips and the lumbar spine, do they have pretty lousy core stability where they're landing in almost a chest facing down position? And where we found that increased hip flexion angle might be a predictor of ACL injury, or are they landing with the knees cranking inwards into knee valgus and hip internal rotation and adduction? Again, I said it again, it's low-hanging fruit. These are patients who we can not only prevent from tearing their ACL, but we can really try to help them be better athletes in general. One of the things we try to do at my clinic, we've been reaching out a lot, is doing functional screens for sports teams and even CrossFit gyms and all types of folks in the community. And whether you use an FMS type system or you just create your own system of looking at jumping technique, landing technique, cutting technique, and kind of quantifying or even qualifying some of the different factors that we discussed here. These are people that we really can get out there and help. And the even bigger population with the bigger issue is probably the re-tears. Folks who have gone through maybe some sort of rehab process for a few months, and then were forced to stop because of maybe insurance, maybe other things. And now their options are either to get a trainer of some sort or to just figure it out themselves and get back to sport. And I think it's an area that's missed, and we could probably do better.
I agree. And I'm actually, now that you mention that, I am seeing a patient right now who is on her second ACL reconstruction of the ipsilateral, so of the same knee. When asking her about it, she had mentioned that there was about a 6-month gap in between her, from essentially when she was discharged from PT until her next ACL tear. So, what's that?
It happens all the time.
Yeah, and we'll be talking more about this return to sport criteria in the coming weeks, but one of the issues I'm having with her is that she just really has a difficult time getting any sort of quad activation. So that thing is shut down. And she doesn't really have much hamstring activation either, so she doesn't have that protective mechanism. So part of the reason, so one of the things that we mentioned was, or I had mentioned, was how the quad kind of gives that extra pull, right? And what I didn't talk about much was the difference between the quads to the hamstrings. So yes, the quads are going to be stronger, right? There are 4 of them. The hamstring, there are 3 of them. So quads will naturally be a little bit stronger. But it's the imbalance that you're looking for. So when we go to return to sport, we'll talk about some isokinetic testing that goes on to try to check the ratio between the quads and hamstrings, which is very important. But, you also need it in the eccentric phase of this deceleration, right, Corey? So again, if the quads aren't working very well, then that ACL is really taking all the brunt of sort of those forces that are occurring at the knee. So it's a lot to look into. On the surface, ACLs can be simple, but they could also be quite complex as well, especially when you're talking about returning someone to high-level sports. So, Corey, any last bits and pieces to add?
No, I'm excited about progressing on in this series here because, again, my big goal today was to really push prevention and looking at risk factors. But I'll tell you what, if someone does tear their ACL, again, it can be really rewarding to bring someone through that whole process and get them jumping and landing and cutting and feeling confident in their stride.
Yep.
And it's a lot of fun.
Yep. Agreed. So, we appreciate you sticking around with this this first installment of the ACL series. We got 2 more coming at you. Next week we'll be talking surgeries. We'll be talking grafts. We'll be talking, some more conservative choices or.
Some
options.
PRP.
You gonna talk some dry needling, Corey?
Yeah, maybe.
Perfect. Can't get away from it. So, looking forward to that next week. We appreciate everyone sticking around, listening to us. That is it for us this week, though. Everyone have a great night. PT Forensics.